community started the patient movement catalyst to put patients in the driver's seat in healthcare and leverage the social participation resolution. This global movement is already working on strengthening community leaderships in health systems. And if you're not yet part of it or you want to learn more, there's the QR code, which again will come up later as well. Similarly to the patient movement catalyst, the From Testing to Targeted Treatments program developed demonstration pilots to bring global expertise to the local level and create impact in a collaborative way together with patients and co-led with patients. There, it's really about implementation of global frameworks, tools, and resources at the local level, learn from them, and scale what works good or what works best in different contexts to other countries and contexts. There's several examples from champions that are here as well, like from Nigeria, Canada, Spain, and Hungary, and many more that you can learn about and hopefully learn from and replicate potentially. But now it's about your expertise and taking all of this work to the next level. So we will be focusing today in this session on the nexus of the global level to the local level. And we want to co-create with you actionable pathways for the implementation of global policy frameworks in a patient-led and partnership-based way. These insights you will be sharing will directly feed into the WHO's, the patient movement catalysts, and FT3's journeys to create impact where it matters most at the local level. And just to remind everyone, we are all here part of the PEOF community, and we come with open minds. We welcome newcomers, and we are brave to ask difficult questions, and we do dare to answer them. So I believe you know that community partnership is possible, but your role today is to make it a reality, from global to local, from concept and policy to impact. For that, we want to leave this session with concrete strategies for real-world piloting of global policy frameworks, and in particular, the joint statement of cancer care priorities. Our speakers, that I will introduce in a second, will give you a crash course on their activities, and then we will dive into co-creation, both in person and virtually. So I'm excited for the presentations, and my intro will end now, so I'm happy to quickly introduce the speakers. We have Tess Padayachi from the WHO Cancer Team and Heba AlSawahli from the WHO's Eastern Mediterranean Regional Office join us virtually, and they will speak about the Joint Statement of Cancer Care Priorities, global policy formulation, and its regional relevance. With me on stage is Carolyn Taylor from Global Focus on Cancer and Abigail Simon-Hart from the Bricon Foundation, who will share their experiences connecting global policy with impactful work at the local level. And with that, I will hand over to Tess, who will start presenting virtually. So I hope there will be a switch.
Hi, Vincent. Are you able to hear me? Good afternoon, everyone. I'm so happy to be here with you. My name is Tess Padayachi, and I'm from the WHO Cancer Team at headquarters in Geneva. And today I'm here basically to set the scene and to share some of the outputs from our very successful meeting in September last year, where we convened about 130 people with lived experience of cancer and emergent leaders to develop a set of asks, priority asks for governments, for WHO, and the broader development community. Now, this statement of priorities will likely form the basis of your discussions today, but please also bear in mind that we are on the road to a very important high-level meeting on NCDs that's due to take place in New York in September this year. So there's much work to be done to highlight the needs of people with lived experience in the context of NCDs. Next slide, please. Today, I'm going to provide you with some insights in terms of WHO's lived experience portfolio, and I'll briefly outline the overarching asks for for WHO and governments. And I'm also going to summarize some of our ongoing efforts in terms of moving us from intention to action. Next slide, please. As a brief background, many of you here today are very familiar with WHO's global campaign to amplify the voices of those affected by cancer, which built on the framework for meaningful engagement of people living with NCDs, mental health, and neurological conditions. The purpose of this campaign was to identify barriers to implementation in the provision of people-centered cancer care, to provide good practice principles, to move us towards more concrete actions, and to advocate for broader policies and programs. Next slide, please. Now, this campaign was set against a backdrop of three very relevant resolutions that call for greater efforts to include people in the design of their health services. In 2016, the resolution passed called for strengthened and integrated people-centered health services. Sorry, are you able to see my slides? So just go forward. One back, please. Back, please. Further back. Yes. One forward. Yes, perfect. So in 2016, as I mentioned, the resolution passed called for strengthened integrated people-centered health services. And in 2017, the resolution passed called for cancer prevention and control in the context of an integrated approach. And most recently in 2024, the resolution passed called for social participation in the context of integrated healthcare. Now, all three of these provide a clear global mandate for meaningful engagement of people and communities affected by NCDs, including cancer. Next slide, please. So while our campaign was our first effort, to take concrete steps in the implementation of the meaningful engagement framework, it was also the vehicle that drove us towards defining a more comprehensive framework of action that gives us direction and focus. Now, we understand from our experience in engaging with people with lived experience that meaningful engagement is more than just a call to action. It's more than a framework, and it's more than a campaign. It needs a clear strategy and a plan. At WHO headquarters, our approach to advancing the agenda for people-centered cancer care is a structured 5-pillared strategy. Now, these pillars enable us to gather evidence, understand policy options for better social protection policies, and to build a network to share resources and strengthen local advocacy. Now, we recently added a 5th pillar, and I know it's a busy slide, but you'll probably have access to this after the meeting. But the 5th pillar is really there to highlight the cross-cutting work that we have to do to ensure that we integrate lived experience into our broader cancer work streams. Next slide, please. Now, we've made steady progress on all pillars, as shown on this slide. In 2024, we convened, as I've mentioned, 130 people with lived experience of cancer and emergent leaders to develop key priorities from their own perspectives. And our global survey on the lived experience of people affected by cancer is currently underway, and we hope that it will provide us with insights into the broader issues facing not just people with lived experience of cancer, but also their caregivers and families. For Pillar 3, we've made the first steps towards understanding social protection policies for people affected by cancer, and we've begun engagements to develop our database of global policies. Our CAP community is in the early stages of development, and we plan to leverage networks in regions and across partnerships to broaden our reach and impact. Next slide, please. So our statement of priorities have defined specific asks for government, for WHO, and for the broader development community. You can click forward. And again. So governments are required to provide timely and equitable access. Next slide, please. Timely and equitable access to cancer diagnosis and treatment, to strengthen healthcare infrastructure and the workforce, provide financial and legislative support for cancer care, provide psychosocial and holistic support for patients and families, and to ensure inclusive policy development and public engagement. Next slide, please. So the asks for WHO, on the other hand, overlap somewhat with the broader development community, but the distinguishing ask for WHO is for it to play a coordinating and facilitatory role in engaging people with lived experience of cancer in a meaningful way. They are asked to institutionalize the engagement of people with lived experience in cancer care broadly, leverage innovation and digital health, strengthen surveillance, monitoring, evaluation, and knowledge sharing, support the provision of comprehensive and inclusive cancer services, build capacity and empower people with lived experience, and finally, provide inclusive and diverse representation. The important aspect of moving from ideology to implementation is to find that elusive sweet spot between governments, partners, and communities affected by cancer, and for us to work synergistically towards shared goals. We live in a very different society with much uncertainty. However, what we've learned through our engagements with people with lived experience thus far is that when they truly feel part of a process, they are the most powerful forces for change. And so the power is in your hands. Next slide, please. In the next few months, WHO will begin disseminating the statement of priorities more broadly. We have a lot of work to do with very little capacity, but we will no doubt have to rely on partnerships and strategic alliances to progress. And while the agenda is challenging to implement in uncertain times, it's also an exciting time for us to experiment and find new ways of thinking and working. Next slide, please. So on this slide, you have access to the statement of priorities for those who didn't manage to get the snapshot earlier. And you also have a link to join our Cancer Lived Experience Knowledge Action Portal, where we'll be posting a lot more of what we are doing, and you'll be able to track our progress. Next slide, please. And to the many people who have inspired us, who have worked with us to get to this point, we say a huge thank you. It's been a huge community thus far, but we are looking forward to working with a much bigger, broader, more dynamic and diverse group over the next coming years. Next slide, please. I now hand you over to my colleague Heba from EMRO, who's going to take you through her insights into local implementation in terms of meaningful engagement. Thank you.
Thank you so much, Tess, and good afternoon, everyone. Good morning, good evening to those online. My name is Heba AlSawahli. I am a consultant WHO Eastern Mediterranean Regional Office based in Cairo, Egypt. Next slide, please. And I'm so pleased to be here with you today. And here is a snapshot of our Eastern Mediterranean region, which is a home to almost 760 million people in 22 countries. With very diverse health infrastructure, income level, emergency situation, and humanitarian need. So in these countries, we have almost half of them facing emergency situation with increased displacement, disruption of services. And we see that the number of cancer cases in the region is expected to more than double to get close to 1.8 million by the year 2050. At the same time, cancer control capacities remain very challenged by the large inequalities between and within countries, aggravated by political instability and conflicts. Within these complexities, number and figures fall short in describing the burden of cancer in the region. We need to hear hear people with lived experience and zoom in and understand what it really means to live with cancer under those challenges, not only for patients, but also, as my colleague Tess mentioned, for the caregivers, families, and the communities at large. Next, please. But how do we do that? So the WHO framework for meaningful engagement of people with lived experience provide guidance on principles of engagement. It describes what an enabling environment for such engagement looks like. And it also outlines possible actions by governments and by WHO. The framework was developed through rounds of consultation with people with lived experience, and the definition of meaningful engagement is respectful, dignified, and equitable inclusion of individuals with lived experience in processes and activities within an enabling environment. I really like this part in the definition. With it values the experience and the lived experience as a form of professional expertise, where power is transferred to people, valuing lived experience as a form of expertise and applying it to improve health outcomes. Again, those are big terms and ambitions, and how this can be translated into actions. Next slide, please. So, as requested by people with lived experience in the priority of statements, WHO is playing the facilitatory role with the ministries of health in the region. We are the first region in WHO to implement this framework. So here are photos from Syria and Morocco, where we started our first round of countries implementing the framework through 4 main pillars. Country dialogues, where we involve people beyond the hospital experience. We want to know what is the whole journey of cancer looks like, how people are deprived from their rights to education, to work, and even how cancer can lead to family disruptions sometimes. And also, this sort of country dialogues is complemented by a needs assessment on ground during these dialogues and through other tools to understand what are the pressing needs to enable the environment for meaningful engagement, and then proceed into co-creating like a set of priorities with people with lived experience and concerned governmental stakeholders and non-state actors as well, to develop a tailored plan for each country. As I mentioned, countries vary a lot between their context, so we need to tailor the actions according to the needs. So examples of the concrete actions that people are working on, we have some initiatives around mental health for childhood cancers. We have an initiative around building a digital platform for networking and training. And also we have an increased interest in the region in patient navigation and at the level of the community and within healthcare facilities. Next slide, please. So here I just wanted to take a moment to appreciate the expertise of people with lived experience in our region. And I'm exceptionally grateful to the women in the region who lead many community organizations at the community level, despite the challenges in their countries. We have different challenges. We have a person from Gaza, occupied Palestinian territories. We have people from low middle income countries such as Morocco, Jordan, and Egypt. We also have a person from Syria who you might have encountered in WHA side meetings. And also we have a lady from Emirates, which is a high income country. So all these people are not afraid to tell their stories. They are inspiring change in their local communities within the resources they have. Next slide, please. So running into the 5 countries we are implementing in our project, we have an initial focus on these countries, and we have these reflections that I want to share with you, and I'd like to hear from you in the breakout groups and the co-creation process, please, because we have learned that, and you guys are experts in this, and I believe the room is full of people who have been doing meaningful engagement for decades. So we all know that people with lived experience are not a homogeneous group with unified needs and interests. They'd rather have gaps and problems that were not addressed for a long time. So they are usually perceived as people with homogeneous or similar needs. So we work together with the governments to change the mindset, and we knew that people with lived experience had the commitment and expertise and passion to drive the discussions, and they are not intimidated by sitting at the same table with policymakers. Also, the ministries of health, which are the historic partner with patients and their families, they could lead this change in these countries. They just need to align their plans with the plans of people with lived experience. And also, despite the diversity between the countries we are working in, psychosocial support and psychosocial needs still come on top of the needs of people with lived experience. Probably I am over time, but I just want to, next slide please, to tell you that in the upcoming stage, we are looking forward to expand our work beyond the Eastern Mediterranean region, within and outside it, because as I mentioned, we need to learn from other regions, from other experiences, successes and failures, and work together to build the capacities of our national stakeholders. Thank you so much, and looking forward to meeting you again. Back to you.
Thanks so much, Heba, and everyone at WHO. I'm Carolyn Taylor, and it's my honor to be here with all of you at my first PEOF. Also, I wanted to share that I'm on the steering committee for the symposiums on meaningful engagement for the WHO ahead of the meeting coming up at the UN this September. I was also really honored to be president of the priority statement meeting in Geneva last year, and I've worked extensively on the Global Breast Cancer Initiative framework and the implementation in Sub-Saharan Africa. So I'm going to share with you today about VOICE, which is Voices of Impact for Cancer Equity, not as a universal model, but as a case study of what's possible when people-led advocacy uses global frameworks to guide local action. So what we see across Africa is that too many women still face delays or denials in accessing cancer screening, treatment, and support. These aren't just gaps in services, they're symptoms of exclusion from planning, from policy, and from power. VOICE was created to help shift that by equipping regional advocates with the tools, knowledge, and partnerships to lead meaningful, context-driven reform rooted in lived experience and aligned with national priorities and WHO frameworks. VOICE, again, stands for Voices of Impact for Cancer Equity. It's a regional initiative focused on women's cancers in Africa. It is aligned with WHO frameworks and regional and national cancer control strategies and policies. What makes it stand out is its foundation in shared leadership. People with lived experience, clinicians, researchers, and policymakers co-creating real solutions from the start. It is not a top-down initiative. It's a partnership grounded in trust, equity, and the lived realities of cancer care in the African context. VOICE is closely aligned with AORTIC, the African Organization for Research and Training in Cancer, which connects cancer professionals, researchers, and policymakers across the continent. AORTIC's biannual conference, the formation of an advocacy special interest group, and the inclusion of a dedicated patient advocacy track at its upcoming November meeting were key catalysts for VOICE. And I don't know why the slides keep moving, but I haven't touched them. We'll go back. So AORTIC's current president is the lead of the advocacy special interest group, or both of the current president and the lead of the special interest group both serve on the steering committee, helping to ensure that the initiative remains regionally relevant and sustainable from the start. So VOICE was shaped by 4 WHO frameworks, not as blueprints, but as design tools that helped guide VOICE's design and alignment from the outset. The framework for meaningful engagement guided our shared leadership structure. The joint statement of priorities emphasized dignity, respect, and the importance of resourcing lived experience. And the breast cancer and cervical cancer elimination strategies helped us align with global goals that were rooted in local realities. But aligning the frameworks wasn't enough, and here's how we put them into practice. Not as boxes to tick, but really as shared values shaping every decision. The framework for meaningful engagement guided the leadership structure, as I said. Our steering committee didn't just approve the plan, they built it. They developed the strategy, they set the learning objectives, they prioritized the themes that mattered most in the context. The joint statement of priorities reminded us to ensure participation was not just welcomed, but resourced, with attention to accessibility, language, and inclusion. And the breast and cervical cancer strategies helped us stay focused on the health system gaps that disproportionately affect women in the region. So our advocacy efforts could be grounded in both lived experience and public health priorities. This is what co-creation looks like in practice: shared power, regional relevance, and design choices led by those closest to the realities of care. Phase 1 began with the strategic planning session in Nairobi last February, where all the steering committee members came together to shape the direction and priorities of the initiative. That led to a 4-part bilingual webinar series, which we just launched last week, actually covering advocacy, policy mapping, stakeholder engagement, and implementation. Each session is grounded in the WHO frameworks, helping participants apply them directly to their advocacy work. But Voice isn't just about learning, it's about action, connection, and visibility. Phase 2, if fully funded, fingers crossed, will bring participants to the aortic annual meeting, not only to develop locally driven advocacy action plans, but to build partnerships, engage with regional stakeholders, and participate fully in aortic's advocacy and patient-centered programming. This integration is really key to ensuring that the momentum built through Voice translate into sustained influence and collaborative action. Success isn't instant policy change, but momentum. It's stronger networks, it's better informed strategies, and more inclusive advocacy. If Voice works the way we envision it, we'll see real shifts, plans rooted in lived experience, better alignment with national and global priorities, and advocates not just in the room, but shaping the agenda. Voice isn't merely about training advocates. We have far too much of that out there already. It's about supporting those already driving change in their communities. When we treat lived experience as evidence and data that it is, and co-creation as the norm, we don't just improve policy, we make it more just, more effective, and more sustainable. And as we move into the co-creation session in a little bit, I hope that Voice offers not necessarily a model, but a possibility for what using the WHO framework to drive meaningful, locally grounded change can be. And with that, I say thank you.
Okay, I'm the one that does it, is it? Sorry about that. Good afternoon, everybody, and thank you so much for joining the session. I'm Abigail Simon-Hart, and I'm the co-founder of the Bricon Foundation, a charity based in Nigeria. And I'll be talking about converting global mission to local vision and some of the stuff that we have done. So my initial thoughts when I was asked to join the WHO thing was, those documents are always really cumbersome. They're what you can say in 2 paragraphs, you say it in 300 pages. The next thing was, am I even qualified to get involved? And they tell me I'm an expert, so I went with it. So the reason I accepted to join the panel and the discussion was, it's my duty, first of all. And if I don't get involved, how can I grumble when my issues aren't being addressed? And I actually have a chance to make a difference. And more importantly, I can take it back and I can localize it. So it was a huge privilege to chair it. And what I discovered is that frameworks are only useful when they actually reflect the need of the people that are using them. They have to be contextualized, otherwise it's a total waste of time. Everybody has a role to play. And so what we decided when I got back to Nigeria was, why don't we have a cancer survivor conference and bring together all the stakeholders, especially survivors? So what do? We had Nigeria's first ever cancer survivor conference. It had never happened before. And what we did, in November 2024, we brought together 80 cancer survivors in one room, together with other NGO leaders, government members, they didn't dodge, clinicians, and nurses. And so basically to get everybody that mattered in there and ask them all the questions that they wouldn't get a chance normally to be confronted with. And we didn't let them off very lightly, I'm afraid. And it was tagged Harnessing the Power of Lived Experience to Transform Cancer Care in Nigeria. But the policy is only as good as what you make it in your own environment. So we discussed barriers and challenges faced by cancer patients in Nigeria. So we put all participants on a table, 10 tables of 10 people. We made sure we put one government person in strategic places where we knew we had very strong advocates. And we said, what do you see as a pain point? What do you want solved as a cancer patient? Where are the areas you want to be touched? And we discovered that there were 7 main pain points, and we got them to be presented by one cancer advocate on each table. First one was access to healthcare and medications. And it was limited due to cost, lack of funding, because in Nigeria and a lot of the developed world, a lot of it is out of pocket. And there's not a lot of knowledge about what's out there. In our country, we have less than 10% of national health coverage in terms of healthcare. And it needs to be increased to have cancer cover in there. Cancer drugs have to be subsidized, and there's a need to combat fake drugs. There's a lot of fake drugs in our country, although that's being addressed now, thank God, by NAFDAC. Another very important issue was stigmatization. Stigma is still making people really afraid of going for treatment. And so we need public campaigns with people with lived experience to show that cancer can be survived. When I was diagnosed in 2014, people were wondering, who's this crazy woman who's coming out to say they took her breast off because she had breast cancer? What's wrong with her? Are you not ashamed? And mine was, look, if it means coming out means that women are going to come out and show that cancer is not a death sentence, then I have done my job. And thank God now in Nigeria, more and more women are coming out and standing publicly saying, I had breast cancer and I'm not ashamed. So people aren't asking for their faces to be blocked anymore. It happens in some places, but we have more and more people ready to stand up on camera and accept and state that they've had cancer. And we also said that there needs to be involvement of religious organizations as well. Because very often you find that there is some element of stigma coming from religion as well. Your faith isn't strong enough. Why are you going to the doctor? Prayer is supposed to heal you. And these are all the kind of things that we need to look at. And then, of course, incorporation of cancer clubs into education as well, because you have to start young. Another issue is mental health. There's little or no support for mental health in our country. Talk less if you're a cancer patient. So we have to strengthen family support and for patients and their families, because people always forget the husbands, the children who are really suffering as a result of their loved one suffering cancer. We need to work with religious organizations as well, because they need to demystify cancer in the first place. And we have to integrate psychotherapy into multidisciplinary teams and engage people with lived experience as part of those support teams. Then navigation of the healthcare system. It's so difficult to navigate. There's brain drain in all over Africa. We currently have, I think it's 70 oncologists in our country, 200 plus, I think they say it's 220 million people. You can do the maths yourself. So we have to really focus on preventative health, because prevention is cheaper than cure. And it's not just a matter of training more people. You have to retain them. Give them an environment that's conducive to stay back. Otherwise, you're training for somebody else's country. We're all aware, I'm sure you go to a hospital in the UK and everywhere, and you see Nigerian doctors, nurses, healthcare workers, support workers, social workers. We have to retain our own people. And we need to integrate patient navigation as an integral part of holistic care in Nigeria and the rest of the world, and involve people of lived experience. There's nothing better than somebody comes to tell you how to navigate, and they've been through the system themselves. Another thing that's really important in Africa and the low and middle income countries is religion, spirituality, and faith. You cannot ignore that. And very often this leads to delays. People come to the hospital as the last bus stop. They come when they've tried the prayers, they've tried the holy oil, they've tried everything else, and when nothing has worked, they come, by which time it's already late. So we need to educate religious and traditional users. Use religious outreaches to do medical outreach as well. We're seeing that a lot in Nigeria at the moment. We need to incorporate health programs into our religious activities. It's really important that we do this. There's a huge neglect of childhood cancer. There's a bit more awareness now. Nigeria currently has 42% of its population is under the age of 14. 42%. 87% are under the age of 45. You can do the maths. 70% are under the age of 30. So if you do not look at the issue of taking care of pediatric health, we're in serious trouble. We're yet to have a dedicated pediatric center. So that means we have 94 million odd, and we don't have a dedicated cancer center. These are all the things that are in progress that need to happen sooner rather than later. There's lack of support structures. The challenge is you survive your cancer, which is a privilege in the first place because many people come late. Then what happens? You're broke, you have no job, you have no prospects, nothing. So survivorship continues after treatment. We have to look at how can we help people with this. So what is the solution? Partner with private and public sector to create employment opportunities, provide micro grants, provide mentoring, provide vocational training to get these cancer patients back on their feet. So how did the WHO initiative help our local efforts? First of all, we all know that WHO initiative emphasizes on equity, inclusion, and shared power. Our conference created a safe space to tackle the issues with government and other stakeholders. And what did this teach us? It taught us that co-creation is rooted in respect, power sharing, and valuing lived experience as expertise. The global initiative says lived experience is central to shaping policy priorities. What did our conference do? It showed that survivor stories are real. They really highlight local gaps in mental health and stigma and all the other areas, and that lived experience adds depth and relevance to priority settings. WHO said we need to empower people with lived experience to lead, facilitate, and co-author outcomes. In our conference, survivors stepped into leadership roles during and after the event. And this showed that leadership can emerge when people are encouraged to stand up and lead with support. The WHO initiative talked about addressing broad themes like access and survivorship. In our conference, these local needs were reflected and contextualized, and that's the most important thing. It has to be in context, otherwise it is not worth the paper it's written on. And the lesson we learned was that global priorities must be interpreted and adapted to local settings. Then finally, the WHO initiative talked about building long-term partnerships with affected communities. And in our conference, every single participant expressed their desire to continue to be involved with what we're trying to do. And this just emphasized the fact that co-creation is an ongoing process. It's not a one-off. It has to be an ongoing process, adapting all the time to the changes and the environment in which we find ourselves. We started our RISE project in partnership with Nivea Beiersdorf, and what they're doing is they're enabling us to rehabilitate, integrate, and support and empower patients. So what we're doing is that we're giving microloans. A certain amount of money is coming from every product sold in Nigeria over 2 months, which will go into a central pot, out of which we shall provide microloans for restarting businesses, for starting businesses, for vocational training, and there'll be mentoring, because you need to help these people to get back on their feet so they can empower others. So we're making progress. We're going to have our second Survivor Conference coming up that is tagged We Rise, where we're going to recap on what we have achieved from the previous conference. And we're going to provide some basic financial training, because what you find very often when people do small businesses, they don't understand the dynamics of buying and selling. It's really important that they understand that they need to make profits as well. And then you can already see from what Carolyn has said, that we're making progress in terms of advocacy as well. A lot of cancer survivors think that talking is enough. It is not enough. If you don't understand frameworks, if you don't understand policy, you cannot make the change that you want to see. So I'm going to end this with a quote. And this is by Dr. Martin Luther King, who says, of all the forms of inequality, injustice in health is the most shocking and the most inhumane. So as we're here and we're co-creating, I hope that we'll all sit and think about it from a global perspective, and that we all put our hands together and make a difference so that everybody actually benefits from all these resolutions that are coming out. Thank you very much.
Thank you so much, Abigail. Thanks, Carolyn, and thanks, Heba and Tess online. We have about an hour left for some co-creation between us. And I will give a quick overview of what we're going to do, but then we'll discuss in detail in breakout groups here around the tables in the room, but also virtually. As I said before, we want to get your insights to inform real-world piloting of global policy frameworks in local settings. And for that, we have prepared 3 steps that we will go through together, where we try to build strategies on partnering to transform local frameworks into the local context. Who are the key stakeholders that are needed and that can help make change happen with global insights and expertise at the local level. Then we will see how we can use global frameworks in local contexts that differ all tremendously. So we'll have a high-level global framework, but what does that mean at the local level, as Abigail pointed out? And ultimately, we hope to look into some immediate next steps that each of us could potentially take to help drive impact in different countries with the different global frameworks that we have been learning about today. So let's go into the rooms, to our tables and into the virtual breakout rooms and start the co-creation. Sorry, there's also canvases on the tables that we can turn around, please, the team, and then we can start going through the different steps.
Maybe you heard something that I haven't. All the access to information once achieved ourselves.
streams full of information. I come from the sports market, so zero knowledge of health. My cardiologist is part of a team of 17 cardiologists, first line cardiologists at CSI 17. As you CSI, same hospital, they 31 sites. Now, looking for cardiologists. In Belgium, there are 107 sites looking now for cardiology. How in Bosnia, every single 17 frontline guys or ladies know every single airline and exclusion criteria. Do every 20 minutes to trace a few more patients. It's just not feasible for us. That's why you need a really even the core of every single individual to is placed in the foundation and it can serve for prevention, but also for selection of patients for alumnus, for surveys, but also for scale. That's the scale. Yes, it's very powerful and scary, but I believe that all these things, this is what's coming.
You're totally like we just worked on championing refugees that was adopted in the and that's exactly the challenge now that we are trying to figure out is that this happened. Now how does it get implemented? How do you get governments interested in the fact that there is this global and first, we have a resolution that we're doing a framework and then our global action plan and then the implementation and
very local levels. coaching to do it and what I see is, sorry, that's distracted. The sports movement is very well organized with governance and constitution. When the rules change in high jump from the top international federation of high jump to the local club in Galilee, we know that the march sorry, that's where the university is changed now high jump by ski distance. So it's a very short, but the sports movement is maybe a very good example of something that is working not only and top down.
The bottom line is that if they're not aware of the changes that they're what they're going to be eliminated, they're not. Like, but it's so important to them to know.
But it's also
Not optional.
it's a rule to participate in competition. But the competitions are really it's the local provincial championship that's that.
Because saying I didn't know about this change doesn't mean they'll say, okay, next time you'll need to change it this way. Well, let's still let you participate, right? Like that's the deal breaker.
Some kind of accountability.
But when we see patient movement is international federations have diseases of this or that, and very local clubs with local people in Brussels.
So it works, but it's like, what's the accountability that's built in with the penalty, right? And so we've been thinking about this just around this resolution. We're looking at dashboard accountability, and that each country we're rating their ability to actually. And then there's health accountability, and then for patient organizations and others in civil society to hold them to account and say, you're not doing this. Why are you not here? So that, like, there has to be. Oh, really? Yeah, I think numbers, it's the only way.
Well, that's it. And that was the thing.
Hi, everyone. I'm so sorry to interrupt, but we are running out of time. Where are we going? Yep, the timer didn't work, but I kept time. So, so we are, oh, sorry, this is for the virtual group. And I just, after this fruitful discussion we had, and I hope you had at this table as well, I just wanted to reiterate that this will not stay here in the room. Everything you have shared will be packaged, digested, and brought back to our partners at the WHO. Carolyn will take it with them, Abby will take it with her, and we'll continue the collaboration to drive meaningful engagement, both at global and local levels. and we hope that you can be part of this. For the WHO, I was asked to say that this is also part of their efforts to influence the global NCD agenda that will be decided at the UN General Assembly at the 4th high-level meeting on NCDs in September this year, which will actually extend well beyond the next years until 2050. So let's hope that that yields some good results. And yeah, with this, I hope you had fun. I hope you found it insightful, and I hope to see you around the next days. I have a little map. If you want, you can put yourself on the map, and we'll make sure to reach out to you and continue the co-creation. I'll put that at the entrance. And here are some more QR codes in case you want to get in touch with the Patient Movement Catalyst, with FT3, with the meaningful engagement teams at the WHO, or directly join the Lived Experience Knowledge Action Portal. And then, of course, Abigail and Carolyn are here, and you're free to connect with them. Thank you.